As everyone was busy in discussing remdesivir, hydroxychloroquine, plasma therapy, and Oxford University vaccine, Israel government has surprised everyone by saying that they have developed monoclonal antibodies, which can track and kill novel coronaviruses inside the patient body. So what are those monoclonal antibodies, how effective they are? We need to discuss this today in the dialogue. We have today with us Dr. Abel Lawrence. He is the professor of immunology at Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. And then we have Dr. Om Shrivastav. He is infectious disease expert at Jaslok Hospital and Kasturba Hospital, Mumbai. And we have Dr. Shailendra Verma, who is the professor and HOD of Hematology Department, King George Medical University, Lucknow. Welcome to the show, everyone.
Thank you.
Thank you. Thank you.
Dr. Lawrence, what is the scope of monoclonal antibodies in COVID-19?
In theory, monoclonal antibodies can be seen as a much more refined and targeted version of this, convalescent plasma. In the case of convalescent plasma, you have what is called polyclonal antibodies. Antibodies produced by patients, they are uncharacterized. There will be many antibodies which are then used for patients. So, but the thing is that each patient may be different. So it's like a blind kind of therapy in the hope that it may work. On the other hand, the very idea of monoclonal antibody is that you have a well-characterized antibody which you can prove that it works in animal models. You can conduct trials just like another drug. And then once it is validated, it can be mass produced and used. This is the promise. But there are a lot of problems with this. So first of all, we need to validate it just like any other drug. So, and as other panelists would agree, monoclonal antibody showing activity, that is so-called neutralizing activity in vitro, which is what the status of the Israeli antibody is, does not necessarily translate to effectiveness in clinical trials. This has been shown by other successful examples of use of monoclonal antibodies like in Ebola. For example, after the in vitro neutralization studies, you need to go to small animals like mice, etc., where if it works, then you need to try it in larger non-human primates like macaques, which are susceptible to this coronavirus-like disease. And then if that happens, then it has to undergo phase 1, phase 2, phase 3 trials in humans like any other drug to prove their efficacy. The problem with in vitro studies is that many a time that is the viral evasion mechanisms against antibody-mediated suppression of the virus may be missed. So it is possible, we know that coronavirus has mechanisms to evolve more antibodies. So thing is that it is possible, still possible to have antibodies, but we need to prove that it actually works in human beings.
Dr. Srivastava,
then one more issue. The other issue is manufacturability. So if you want to use these antibodies, these are proteins. They have to be synthesized in very large amounts and mass produce it. So how they are produced? They are produced in bioreactors through cell cultures. Then they have to be extracted, purified, and packaged. And I have been told that a single batch takes 2 months to prepare. And then to establish those production lines, standardizing them, it will take time. So the question is, a pandemic like this, which runs its course for several months to a year or two, that's too short a time for developing a monoclonal antibody. If you look at the history of monoclonal antibody therapy against Ebola, it started in the mid-2000s, and only by a few years ago, we have something which actually can be used in patients.
Dr. Shrivastav, how common monoclonal antibodies are in the treatment of bacterial disease?
So monoclonal antibodies in the treatment of bacterial infections is not very common. There are monoclonal antibodies in a number of situations where there is a situation where there is an infection, but that part of the infection is then mediated through a very large mechanism of the patient's immune system. That is where a monoclonal antibody is likely to work. It's not going to be having a role in the replication of a bacteria or a fungus or a parasite or a virus. It will have a role, but it's a very small role. It's not quite the same thing as having the role on the immune mechanism and immune trigger. So insofar as monoclonal antibodies for infections are concerned, there are very little insofar as a specific monoclonal antibody for a particular infection, but there are monoclonal antibodies that are used in conjunction with an immune process along with an infectious process, and that has been shown to have some amount of success. But do remember that, you know, one of the big problems about a monoclonal antibody is that you are assuming that this clone, which is, you know, a monoclone, a single clone, this clone is going to be able to replicate the entire disease process step by step. Whereas a lot of these processes involve what is called a polymorphism. That means one single target is going to be having multiple, you know, twins or cousins who look alike, but for a very small or a very intricate kind of a difference. So it is not necessary that every monoclonal antibody that looked very good on paper to start with is going to be as effective in practice, but it is a very promising strategy. And if it captures the essence of the disease, then it is likely to be very beneficial, especially in a condition like COVID.
Dr. Verma, your team at KGMU is working on convalescent plasma therapy, and some of the patients have been given this convalescent plasma. So what do you think are the pros and cons of monoclonal antibodies vis-a-vis convalescent plasma?
So if you see the convalescent plasma, this is a very short of non-specific, because in plasma we have many other things which are there which can actually produce harm also in patients. But if we talk of monoclonal antibody, they are purified and they are targeted against a specific antigen on the virus or on the cell, any cell. So in that way, it is specific and targeted, sort of targeted. So that's why the side effects and other the adverse events may be very, very less in monoclonal antibodies. So that is the benefit of that, and the amount also, like in plasma, we have to give a amount which is a large amount, and these antibodies, they are purified, they are small in volume. Sometimes they are in powdered form, sometimes they are in liquid form. So means they are very small in amount. So in that way, it is different from the convalescent plasma.
It would be very easy to handle. That is what you mean to say.
Very easy to handle. Although still with the monoclonal antibodies also, there are possibility of reactions. Basically, if there is any animal protein in that, or if the monoclonal antibody was formed in any animal, then it can have even the reactions also, sometimes anaphylaxis also. So that is also a possibility, because we use a lot of monoclonal antibody in hematological practice. Basically, these are one of the non-chemotherapeutic agents which are used for lymphomas and leukemias. But there the target is the antigen on a cell. A malignant cell or cancer cell has some antigen, and specifically to that antigen, some antibody has been formed which targets that antigen and kills the cell. So actually, that is the idea behind this. But the thing is that for infectious disease and viruses, these monoclonal antibodies have not been found to be that effective till now. Although there are some studies in past where even for this coronavirus also, SARS virus also, there is one study in 2004 which was published, which has shown some effect by these monoclonal antibodies. But the thing is, we have to wait for this, because they have not told where they have done the trial and in which animal or they have done the trial, and there is no data on human trials as of now. So basically, this is a very, very early thing. As Dr. Lawrence has also mentioned, that this is very early to say whether these will be effective or not. And because the virus keeps on changing every time, the antigen structure and the genetic structure of virus is very variable. So maybe whether it will be effective for every time or only for this time, this we have to see in the near future. Yeah.
As you mentioned that we do not know much about this, so I learned that it has been developed by this secret lab that is called Israel Institute of Biological Research, that directly reports to the Prime Minister of Israel. So obviously that is why the Defense Minister of that country announced about it yesterday. So Dr. Lawrence, we are hearing a lot of things like vaccine, and then lot of drugs are being developed, and now this monoclonal antibodies. Which of the therapy you think is going to come first in the market?
although in the previously on our first dialogue, I mentioned that a vaccine might take several years, but seeing the progress that has been that is the kind of work that had been done on vaccine research for the last 10 years against MERS and SARS, I would think that a vaccine might be the first one to come. But I would like to add some more on the monoclonal antibodies, which the other panelists have mentioned. The success in monoclonal antibodies have been mostly targeted at human antigens, like in various types of cancers and in chronic autoimmune rheumatic diseases, where the thing is that those antigens don't change. They're stable antigens, since in the lifetime of the person, it will not mutate. Whereas when we deal with infections, these are rapidly, especially viruses mutate fast, so we have a moving target. That doesn't mean that a monoclonal antibody cannot work. The reason I say it's not practical now are very different. It is possible to develop monoclonal antibodies which target very specific parts of important viral proteins. Like in the case of SARS and MERS, the part of the spike protein which binds to the receptor, if it interferes with the binding of those spike protein with the receptor, and if you target those epitopes which are conserved and are required for interaction with those host target antigens, then it can work, and it has been shown in animals. And interestingly, the new antibody which has been published in the Nature Communication, they have found a new mechanism. It binds to a region other than the ACE2 binding region, but affects the function of that protein, and therefore prevents it from forming fusion and entering the cell. So if the monoclonal antibody targets a very conserved region which is necessary for the virus to function and interferes with the infection, it can work. But prove that this actually does is a very hard process, and by the time all these are proven, it will take time. It has to be proven in clinical trials. And then the bigger reason is that it is one thing to make it in small quantities, but a different thing to make it in sufficiently large quantities to be useful. And even if that is done, all monoclonal antibodies are expensive, and everyone will tell you the therapy which are the so-called successful therapies are expensive therapies, which most majority of the Indian population cannot afford. So in practice, how much it will affect public health is something to be seen.
Dr. Shrivastav, if we talk about treatment and side effects, where does this convalescent plasma and this monoclonal antibodies and the different kind of medicines which are currently being given to the patient or being developed, which method or which approach is better for the treatment purpose and also for the side effect?
So there is no such thing as one specific treatment that's going to work. My mind, if you look at the basic immunopathogenesis or the way the immune system responds to an infection like COVID, it responds at multiple levels. That is why there are variable responses at variable stages of the infection. The same category of a patient, that means somebody who is matched for age and comorbidities and height and weight, and the extent of the involvement of organs will behave differently, and patients will behave very differently on, say, day 1 as compared to day 5 or day 10, 14, 21, 28, like that kind of a, if you were to take a breakdown, you'll find that the immune response is different for different people, and that is why it is now being looked at as a sequential kind of response time that is going to be occurring. And not just a response time, but sequential levels at which the immune system is engaged by the virus and the immune system going into a response. So I don't think it's going to be any one single therapy that is going to be effective. To say that you can use only plasma, or you can use only a monoclonal antibody, or you can use some of the the interleukin-6 inhibitors like tocilizumab, or a combination of the drugs that have been seen so far. To my mind, what is going to work is a combination of all of these agents. When the vaccine comes, that is one. You pick the right patient for the plasma therapy, that is 2. You pick the right patient for a potential monoclonal antibody, that is 3. Or sometimes you'll have to combine all these 3 or 4 regimens in patients who are very unwell or very sick. Plasma therapy, the biggest advantage is that when you've got somebody who is already had the infection, this person is meant to be showing the antibodies. That's why you need to measure what is called the neutralizing antibody of this infection. That means it's not enough for you just to have the antibodies. You need to be able to show that there are antibodies which are going to be neutralizing the infectious molecule in the patient in whom you're going to give the plasma. So plasma, again, if you look at some of the institutes whose protocols have been approved by ICMR for plasma therapy, you've got to time it correctly. You've got to pick the patient correctly and time it so that you don't wait till the time the patient, a patient has gone into respiratory distress or on ventilator and is critical. You pick the patient who is not yet critical but is showing features clinically or laboratory wise or scan wise, this patient who is going to go into this kind of complication. So there are immunological markers, there are markers of T cell populations, there are markers of inflammatory responses, and a combination of the clinical features along with radiological and laboratory markers that will tell you that this particular patient is likely to go into complications. That's the patient you want to pick to give something like plasma. That's the same thing that applies to an agent like tocilizumab. So you've got to time it correctly. You've got to pick it correctly. And I doubt if it is going to be just the one agent that is going to be decisive in patients overcoming this infection. My feeling is, given by what little we have seen in the last 3 or 4 months, it's going to be a combination of factors, of which plasma is going to be one of the key factors, but not the only one.
Dr. Verma, your last remarks, please.
Yes. So I wanted to tell that whatever we are thinking as of now is just for the treatment of the patients who has already got infection or already got complications. So basically, in that way, if you see the monoclonal antibodies also, this will be working in the persons who has got infection, who has got the virus and infection. So basically, the vaccine is the one thing that can only help in a long run. If you see in the near future and the coming years, vaccine will be the only thing which can provide us the immunity like we see in the H1N1 infection, which we had few years back. So the vaccine is quite effective, and we have the annual vaccination. So similarly, we want to have some preventive measure, because the vaccine will be the only thing which is preventive measure, which can prevent the infection in community, and it can help us not to go to all these treatment modalities which we are discussing. But otherwise, for infected patients and patients who are having symptoms, these are the treatment modalities we have already discussed, all these things.
Thank you all for talking with us. Thank you.
Thank you.
Thank you.